So thank you, Dr. Hildebrandt. We appreciate you being here, us getting together to talk about the very interesting work that you have done with Gesundes Kinzigtal. Wanted to hear a little bit more about that, but can you first introduce yourself and the organization for a little bit of background?
Yeah, sure. Thank you. My name is Helmut Hildebrandt and I'm a pharmacist by profession, not a medical doctor. Being a pharmacist, when I was studying pharmacy, I thought that the question of prevention should be much more in stronger regard for all our healthcare professionals than it was in these times. And so I worked with WHO and here in Hamburg with the University of the University Clinic on questions of how to develop health instead of develop diseases, and how we can promote the situation of an improvement in health care on the one side, and as well on the health competencies of the people and the health status for the whole population. And in these times, it was the discussion on the Ottawa Charter for the WHO, for the World Health Organization. Some health futurists discussed topics of building healthy cities and building healthy mega cities. And so that was my background to some extent. And in parallel, I worked as a consultant for healthcare providers, mainly hospitals, and was as well to some time manager of hospitals. And all the time this old question came round, what is the real purpose of healthcare? Is the real purpose of healthcare to have as much diseases as possible, or is the real purpose how to provide health to the people? And in these times when I was executive of hospitals, I worked as well closely with the politics in Germany, and had the possibility of introducing a new healthcare law that was called the Health Reform Law. A lot of names are quite similar, but in 2000. And in 2000, the first possibility arose to develop contracts between consortia of healthcare providers and specific sickness funds to rearrange the way of how to produce healthcare, what kind of instruments are used, what kind of methods are used, and what is the payment system for it. And the possibility for alternative payment systems arose in the German healthcare system. And then since 2000, I tried in different places in Germany and different arrangements to organize a new kind of payment system. And in 2003, I developed my company, OptiMedis. And OptiMedis focuses exclusively on the way of how healthcare may be provided in another way and in other payment systems, and what are the incentives behind it to produce health instead of looking for the newest disease that can be organized.
So I think, I come from the US and my students are Americans, and I think about how we teach about comparative health systems, and so often it's easy for us to think, oh, the Europeans have this figured out. Everybody has access to care, you don't have an uninsurance problem. So what was the problem that you were trying to solve? Anything specific?
In these times in Germany, we had the discussion of an explosion of healthcare costs. And that was one of the reasons for a discussion of new kind of payment systems, because the traditional payment system in Germany encourages each healthcare provider to deliver more care services, whether they are needed, whether they are useful for the patient, whether they deliver health, or whether not.
Fee for service, right?
Yeah, there are some mixes of fee for service and budgeted sums and so on, but in the main idea it's fee for service. And in 1984, I had the opportunity to come to the US and see the early developments of managed care. And so I was in Boston, in Chicago, in Oakland with Kaiser Permanente and others. And so the basic idea remained in my head that there are other arrangements possible.
Right.
So we have the fee-for-service system, and 99% of the healthcare providers in Germany don't look for other ways of payment systems. But in the US, with the managed care model in these times, there was another idea of a payment system. And so we tried, or we thought, quite a long time in between, how the German healthcare system, with the positive aspects of it, with the solidarity model and with the access situation, can be improved by taking into it as well some kind of managed care aspects. And we started, for instance, a German managed care association. Since long years I'm in the board of this Bundesverband Managed Care, and there were a lot of discussions on other payment systems as well. And in the International Foundation for Integrated Care, we discussed as well how other payment systems produce other incentives, how to work with the patients, how to use their experience, how to share knowledge with the patients instead of using the patient as an object that can get some kind of treatment.
So that's great background. Can you tell a little bit about how all of these influences from your experiences here, learning around the world, how did those things culminate in the design that you chose? Can you talk about the design?
Yeah. We had we changed some of the ways of managed care to be appropriate for the German situation. For instance, one important point is that we say in the OptiMedis model that every insured person that lives in a certain region is part of the economic payment system. That does not mean that this person is restricted in the use of other providers. So a person is free to use any kind of provider, without any kind of plus payments or something like this. Second, providers are free. They may decide to go with the new system or they stay with the old system. But there's no, they have not a certain necessity to be on the one or the other side.
Now, to clarify, if they choose to participate in the system, is that a choice per patient or for the physician, and is it a commitment for a year or something?
The physician gets the normal amount of money out of the traditional system. The regular system is beneath everything. They get the normal kind of money. And then from the new system, we develop bodies that are like accountable care organizations to some extent, over something as a paramount over the different providers, and all the patients who are insured by this sickness fund who is partnering with us for this region. And this organization, we call it Gesundes Kinzigtal, or a healthy arena of XY, XY. That is an organization that pays surplus money to those providers who are participating for specific services we want them to provide. So they get fee-for-service in the traditional system and a new kind of fee-for-service now for cooperation work, for working with the patient on a certain new level of cooperation.
Okay. Can you talk about how you brought the stakeholders to the table to develop the model together? Because you mentioned multiple sickness funds are involved, multiple providers, different kinds of providers. How did this convening of all these different people happen?
That is hard work, and I think it took nearly 3 years, 4 years of hard work to find the first one who was interested to work with us. In 2004, a group of doctors from family doctors as well as specialists in one region in Germany, in the area of Kinzigtal, and that's in the Black Forest in Germany. They asked me to come to a workshop with them for explaining what is this kind of integrated care that has been put into the law. And we had a nice workshop on the weekend in a nice area there and some sun and so on. And that developed some ideas and a nice cooperation. And so they decided, okay, we are interested to go forward with your model. So I presented our model, and on the same time, I had a quite friendly contact with some of the people on the board of the most important sickness fund there. Mm-hmm. And so we came to the situation that the sickness fund and the doctors were interested, and that's the big problem. You have to find them in the same kind of mood at the same time, and that's not it's not easy to find that at the same time. Sometimes the doctors want, but the sickness fund doesn't want or doesn't dare to want, or that the sickness fund wants and we don't find any providers who are interested. So that's one of the difficult questions.
Yeah. What about bringing the other provider entities to the table? Hospitals, rehabilitation, physiotherapy, other kinds of mid-level providers?
Yeah, it's quite clear. We have to have every kind of providers at the table. And that's another problem. That problem might be higher in Germany than in other countries, because our sectorization is even stronger. So doctors are used to feel like being in some kind of a guild, like in the Middle Ages. And they are not as much known in cooperation with all the other professions. When I was in the US or in other developed countries, I had the impression that quite often the allied healthcare providers, like in Australia or so, are much nearer to the doctors than in Germany. So there is some kind of a split. So between pharmacists, doctors, physiotherapists, nursing professions, it's a difficult situation. But bringing somebody into a system like we did with the human payment system, then it gets easier. And they realize that they need to get the best profit, they need the other professions as well. So I think interprofessional work will be strengthened by this kind of new payment system.
Now, sometimes the regulatory environment is a problem. You mentioned that 2000 there was a regulatory change. Can you unpack the idea of how that made a difference?
Yeah. Before 2000, when somebody wanted to make a change in, let's say, another kind of contract, it was only possible if you were able to convince all the sickness funds in this area of this other contract. You could not develop something with the sickness fund that was a little bit further on the way. You could only do with convincing everybody. And convincing everybody is in a somehow strict regulatory system quite difficult. So coming from the university, I had a lot of proposals between 84 and 2000 offered to sickness funds, and nearly every proposal got pushed down by the big group of, let's say, 15 people sitting around a table from different sickness funds and associations, and one says no. So I was very lucky that we were able to push a new paragraph into the law that allowed for development of contracts between single sickness funds and groups of providers or management companies who have contacts as well to groups of providers. So that made it easier to move on. Now it's getting to some kind of new problem, because then a doctor or a hospital or a nursing agency has to look for, this is a patient from sickness company A, this is a patient from sickness company B, and they have to be, so their treatment has to be, has probably some kind of differences. That's a problem now. So at the moment we are discussing now a situation to change the law again and provide some kind of incentive to sickness funds to get at least 80%, 90%, maybe 100% of all sickness funds getting into a contract after some time. But for the beginning, for the innovation, it was necessary to work with single sickness funds.
Yeah. That sounds similar to what I hear in the US from some people involved in innovative models for value-based care. They say, well, we don't want to, we shouldn't differentiate between each patient who walks through the door. Yeah. Oh, this patient, you get the old way. This patient, you get the new way. And so there's some discussion about at what percentage of the clinic's patient panel is there the tipping point where they just start treating everybody with the new practice.
Yeah.
Of course, that might not be to their financial benefit with patients who are under the old ways. But that's why that's really interesting to hear that you have the same challenge.
Yeah.
Did they find, because you have been since 2005 with the Kinzigtal model, did they just start to do this, the quote unquote right thing for everybody?
We had the good situation that in Kinzigtal, the sickness fund with whom we partnered had about 44% of all the patients. And then we added another sickness fund that was not in competition with this one, who had another 3 to 4%. So at the moment we have about 50% of all regular covered patients with these two sickness funds. and being part of our system. Nevertheless, we have a problem that it takes effort, it takes work all the time to stay with the conviction, okay, I know half of my patients can be supported in a different way than the regular way. And the regular way is still the default version. So we are looking for a situation that we might have, let's say, 70 or 80% of the sickness funds, so that the new default version is the integrated care model, and the old one, the regular one, is only for 20%, and then it's the way that these get the services as well.
Right. They just change their mode of practice,
yeah.
And they don't differentiate between patients at some point.
Today, we had some sickness funds with whom we discussed whether they join the project, and they showed us data, and they had a good development of lowering their costs because of our work. But they say, oh, why should we pay for it?
Yeah, I get that. Just to confirm before we move on, as far as who needs to be involved, you talked about how important that is to get the physicians. We didn't really differentiate primary care versus specialty. And the payers, as well as some of the others. You didn't dive in very much detail about hospitals, but anything else to add about who you need to bring to the table to make this thing work well?
Yeah. We realized over the years, that we have to look forward. When we started, because of the special situation that we had a network of physicians with whom we partnered, so we were very much physician-centered in our work in the beginning. And we started to realize that this isn't enough. Because in Germany, physicians are so much under pressure, under work pressure, that's really difficult for them to do extra work with the patients, to give them the extra mile for his health improvement, the extra 10 minutes, because then they run into the evening hours.
Yeah.
So we decided first to use the staff of the practices. In Germany they are called medizinische Fachangestellten, medical qualified assistants,
okay.
might use it. And but normally they are only trained on certain procedures in the practice and on administrative stuff.
Right.
And we train them now on that they get nurses, coaches for patients. So for heart failure nurses, for pain, for supporting people with the shared decision making with the doctor, developing, filling out specific assessments, health assessments. So we enlarged their possibilities, and they were very interested in this kind of work. The second, going further on, was then how to work with all the other professions, with the people in the nursing agencies and the nursing homes, with the people in physiotherapy practices, with the hospitals, with the pharmacists. And and that's quite difficult because we don't have so much money that we can pay them for everything. So we have to look for win-win solutions. What is the win for a physiotherapist to work with us in this project, producing health? Because he might fear that he loses some kind of activities.
Sure.
That he can get reimbursed. So we developed new activities, for instance, group therapy workshops for him, for people with osteoporosis. So we gave money for these group activities, but at the same time we worked as well with the voluntary sports associations and trained their trainers in osteoporosis. So we had a stepped care protocol. For those people who were quite frail, we used the physiotherapists. But those who were not that frail, but they came into the situation that they developed an osteoporosis, we trained them with the sports associations. So we tried to look for different subgroups where we put the patients in.
So I'm hearing a team-based approach. You took this existing physician work and especially the additional work. You put that with some of it with nurses, some medical assistants, and then community mid-level or ancillary people, with the physician as sort of the captain of the team, if you will?
Yeah, in these times the physician were the captain of the team, and in the new projects we even changed that. Mm-hmm. Because it's really difficult to find physicians who are able, on the one side, to have their medical work with the patients, and as well looking forward into the new way of being captain in the team of a team of health improvement. That's not that easy. And so in the new projects in North Hessen, that's nearly the center of Germany, we have 2 regions where we are now developing it, looking at all the professions of healthcare at the same time, in the same moment. So we work with the pharmacists, with the nursing, with the physiotherapists and so on, and train people in all these practices and companies to get health coaches, not only the medical staff and the physician practices. Yeah. And we have about 45 health coaches now being trained in this kind of work, and they enroll the patients, they work with them on the first level, and then if they need medical support, go to the doctor. If they need health coaching support, maybe they have a second level support we organize, and then they get into the voluntary system. So working with the German Red Cross, for instance, or with the family counseling organizations or the behavioral health care associations, so that they get support before getting sick.
Right. How do you exchange information or do this information management? It's hard enough within one clinic, within 4 walls, for multiple providers to coordinate on a patient's whole life, let alone when you add a hospital that's some distance away, physiotherapists, nursing, mental health maybe, and other aspects of health that are elsewhere in the community. What have you tried and what has worked best so far?
A good question, and it takes a lot of effort. I think we had about, in Kinzigtal, we had in between 3 people working only on communication inside the Gesundes Kinzigtal company. At the moment, I think they have about 1.5 full-time equivalents. And in the smaller regions now in North Hessen, we even have relatively more people on communication, less in the number of people, but more in the relations. And we use every kind of way of possibility. We use the traditional models of newsletters and so on. We use meetings virtual meetings now because of the corona pandemic, or informal meetings. We use that we go to each practice and bring information to the practices. We have social media, we use Twitter, we use Facebook, we use in Hamburg we use LinkedIn and others. So as it's necessary there, but getting people involved by communication is really a hard job. So it really takes a lot of effort.
I hear there aren't very widespread medical records, electronic medical records. So I'm wondering if I'm the physician for this patient, and how do I know if she's been to this pharmacist and been educated or advised to do something, or been to this specialist or physiotherapist, anybody else in this ecosystem of providers? So how can they know what I have in my records that could help them do a better job?
Yeah. There is one fortunate situation that most physician practices use electronic records, but every physician uses a different one.
Mm-hmm.
So we have a problem of being able to transport the information from one practice to the other. And I think we started in 2007, early 7, with the doctors in Kinzigtal to develop a system that is able to read the data into their practice systems and bring this data to the other ones, to the other doctors. And we had a lot of money we put into this project, and we had all the problems that can be read in other countries as well. So the IT companies who told us there's no problem, we get it, they didn't get it. Then we have a lot of exchange of requirements that these practice IT systems have to follow, and that they change the requirements sometimes every other quarter. That means then the IT system that is looking down into the data and trying to exchange the data has to rework its own procedures as well every other quarter. So that takes a lot of time and amount of money as well. So we had now the third iteration of companies with whom we worked. Now it's working quite nicely, but we have only about 60% of the doctors being partnering with us who use the system at the moment in Kinzigtal. Okay. We try to enlarge it to 100%, but it's investment every other year from about 200,000 euro. And that's really tough.
So otherwise they send each other notes?
Yeah.
Normally,
there is a possibility to send them notes.
Yeah.
But normally it is used to send notes only from the specialist to the family doctor, not the other way around. But the good information would be if the family doctor as well send a note to the physiotherapist back, the family office physician to the specialist and back. So, or not sending, but reading the data that's already produced.
In particular, I had a couple of questions about, as I was reading online, what sounds to me like, from the US side, we would call a public health function. Some basic maternal child, some basic, not in the physician office, of vaccinations, sexually transmitted disease testing, those kinds of functions. In the US, we usually do in a government office that's separate from the physician function. But it sounds like you have some of that mixed into the incentive structure.
Yeah. So we add only things that are not being delivered by government offices. So if government office, or we call it the health authority, are doing a good job, perfect, wonderful.
But they're not incorporated or partnered in?
No, but we are working very closely with them together. But they are just their body, and we are a commercial company on the other side, and normally in Germany authorities and commercial companies are a little bit keep a little bit difference. But for instance, in Eschwege in Nordhessen, in the area Werra-Meißner-Kreis, we are part of their conferences, we are part of their meetings. We have a very, very close relationship. They have a prevention project that is running with money on a federal government part, and we just cooperate and try to do this, to invest into the prevention work they don't do. So we just take there and enlarge it into a further activity.
So that's not a full-on partnership, but coordination,
yeah,
if you will.
Yeah, and for instance, in 2 weeks, we are part of a session of the Health Council in this area. They asked us to show what we are doing there, and they even think about the idea of getting into a commercial partnership so that they get a share in our company.
Sure.
No? So that would be a new way of cooperation. In Kinzigtal, the municipalities, we have a meeting every other year with the municipalities of Kinzigtal, and they tell us, oh, we would need some activity there, we would need some activity there, or could we cooperate in this way or so. So
they might bring up some new emphasis they
yeah,
want to pursue,
yeah.
A new initiative on smoking, for
Yeah.
example, or something.
Yeah, for instance, they have several swimming pools, Schwimmbäder, swimming pools, no. Public swimming pools, and we do a training. We call it aqua training, so training in the water for older people, people with obesity, so that it's easier for movement there.
Like water aerobics or something.
Water aerobics, yeah. And so we bring the trainers, and they offer the swimming pool and the hours in the swimming pool.
They probably put up some flyers to posters
Sure.
for information.
Yeah. Or we do festivals in the swimming pool, trying to get more people involved in swimming and training on swimming and so on.
Another question you partially responded to, but I would definitely want to talk more about it. The rural-urban thing.
Yeah.
Because it's funny, I'm talking to a woman from Leipzig who just moved to Hamburg. She was working in the hospital complex where I was visiting. And I mentioned the Gesundes Kinzigtal. I don't even know where that is. She never even heard of that. I know a different part of the country. But this is a very small area, very rural. The population of the whole place is, 70,000, and you have about half of them. And now in North Hesse, that's similar, small rural population.
100,000 people living there, but the sickness funds have only 22,000.
Yeah. Mm-hmm. So I understand the criticism. I don't agree with it, but I understand the criticism. Oh, well, this is a little small rural thing, and this wouldn't work in Hamburg. This wouldn't work in Berlin.
Oh, she should know better.
She didn't say that, but yeah. How do you, because you've encountered that before, how do you respond to that?
Yeah. We started in 2015 an activity in Hamburg. Mm-hmm. So in not that much rich region in Hamburg, it's called Billstedt-Horn, It's an area of about 100,000 people, with some problematic areas where very low earning people are living, and some high rises and a lot of migrants and so on. So complicated situation there. And we thought rural area prospered. Kinzigtal is a quite prosperous area there.
Okay.
So it's southwest of Germany, and southwest Germany always has quite a high level of earning power. And then we thought we should have it the same kind of project and the same kind of idea in this low income area.
Okay.
And we started in 2018, and it's running still now. We passed it on to an association of neighbors living in this area. And there's a group of doctors connected to it, a small hospital, doctoral association of Germany has 5% of the shares there, and then 30% the regional association of people living there. And there we had a small change in the way we do the work there. Instead of using the doctor's offices as the entry point for the patients, like we did it in Kinzigtal, there we used this way as well, but as well a kiosk model. So it's
where was the kiosk?
In one of the most deprived areas there, on the marketplace in Billstedt. And there we have colleagues who are trained as nurses mainly, and then on top on behavioral aspects, on smoking, on diabetes, on exercises and so on. And so they support the people there. And that was the second model we developed in Germany. And the Nordhessen is now the third. And we use this health kiosk approach as well, but we use now it in any kind of healthcare facility. Because we realized that having one kiosk for 100,000 people is not enough. People don't move so far, especially if they're some kind handicapped or handicapped by the disease or by other impairments. So that is now the third iteration in the way we do. And in France, we try to use even more the way of sports, because in France there's a tradition of sport et santé, sport and health.
Yeah.
And we use it with the sports facilities, so for one of the first points of contact for the people there. And in UK, on the other side, we use the doctors, because the physician offices are really the central focus points for the patients there. Mm-hmm. So in every other region, we try to develop a certain approach that is according to the situation there.
And that's important. That's good to hear. So I may be back later to ask more questions about that. It's one of the things I hope to learn from this research. Which approaches work in which circumstances, mm-hmm. and would maybe fail in a different circumstance. Mm-hmm. Mm-hmm. It's great that you're doing the low socioeconomic status urban or suburban part of Hamburg?
Urban.
That's part of the city, okay.
Yeah.
And then you've got these rural areas, the more prosperous one, in the Black Forest, and then this new one in North Hessen.
And that is a little bit deprived, it's a little bit poorer than in Kinzigtal.
So you've got rural poor, rural not so poor.
Affluent.
Yeah. And then urban poor.
Yeah.
And mixing in, are they more traditional ethnic Germans in the Hessen and Kinzigtal, but you've got a lot of different ethnicities and things.
Yeah.
So some other social determinants of health.
Yeah.
Mixed in
Yeah.
the one in Hamburg.
Yeah.
Fascinating. I can't wait to hear more as things unfold. Yeah.
Yeah, and in Leipzig, for instance, because you mentioned it, we are just discussing in a part of Leipzig, it's called Grünau, to start a project as well. And we have now about 6 to 7 projects in the preparation.
Oh, wow, okay.
So maybe if the new coalition has some incentives for this kind of work next year,
Yeah.
3 years, 5 years, there will be 20, 30, 40 projects like this.
That would be fascinating. Yeah, I'd love to, in the future, maybe we can talk about partnership on understanding those differences and evaluation. It's something I'm really passionate about doing, evaluating what works and when, and how are the outcomes different.
Yeah, and I'm still wondering, Obama with the ACO project, there are now about 270 or 200.
The current number, it
90.
declined after a while.
Yeah, but nevertheless, there are so many projects running,
Yeah.
and it takes so much time in Germany to develop some, at least.
Yeah.
Yeah.
Well, so the U.S. has plenty of problems, but one of the advantages with a decentralized system, a less government-centric system, private industry can just try whatever they want.
Yeah.
And that's part of what I'll be, for these very interviews in the U.S. So the very first interview I did was in the U.S., and it was not within a government program at all. It was with an integrated health system that's going direct to employers for their employed populations. You know, we have largely employment insurance. I'm really familiar with the Medicare ones already and the Medicaid experiments. I'm originally from Oregon, which has a pioneer system on their poor population. It's a lot like what you're talking about. And they are one of the few that are able to do either a full monopoly or quasi-monopoly on a geographic area. So in most of the state, which is largely rural, with one big urban area, a couple smaller urban areas, and then very rural, and different ethnic, social determinants of health problems, so a lot of diversity. But other than the major metro areas, there are usually only one ACO, they call it a CCO, Coordinated Care Organization, that exists. And everybody who wants to get that money from the state, in that case it's the state Medicaid program, they have to participate. Now, of course, some of the people around the table are bigger and stronger than the other people. And that is an issue they've recognized, but they haven't fully addressed yet. But the hospital is there. They bring in the government health departments. The local health departments have to coordinate and share money. That's crazy, radical, different for us, but it's being done. They have just hit 10 years now with this experiment, with some good results, restraining healthcare cost inflation and getting some of the outcomes I've been reading about are like smoking cessation, more access to prenatal care. The very preventive measures that you're trying to do as well are the focus of those, and they're able to adjust them on the needs of the local communities. I remember one of them had a smoking problem. The rest of the state was pretty good. One area, boy, they had high smoking. So they focused on that. The other areas, maybe heart disease or diabetes.
Yeah. Smoking cessation was one of our very first activities in Kinzigtal as well.
Yeah.
Even before the law came into effect in Germany, we had a coalition of restaurants that stopped smoking inside their restaurants. Because I remember quite well one restaurant chief, he told me, it's a small restaurant and I have to use my kids as well. And I don't want them to get poisoned by all the smoke. Best would be if you could talk with the sickness funds themselves. What are their reasons for being reluctant? But I can add my hypothesis. And my hypothesis would be, it's easier to stay with the normal train. So everything is being organized in the regular way in Germany. And staying with the regular way is the way that is the situation that you can't get into any risk, because it's the normal way. Everybody does it. So taking the new payment model is a risk for the person inside the sickness fund, whether it's in the middle body or the upper one. And so that's the first. Avoiding risks is very important.
Financial risk. This is a cultural level for the...
It's a cultural. It's mainly a cultural.
Weird, right. What if it doesn't work? I could get fired or tarnish my reputation. Okay.
Yeah. Second, to disrupt an industry, it's easier if you have a lot of other people who looked for the same kind of way of disruption. But in Germany, unfortunately, we don't have competitors. So we are the single company who is doing this new way of payment systems. There are some other companies or organizations that try to develop new payment systems, but they are not so radical, and they are oriented on very small indications. For instance, looking on COPD and another kind of disease management for COPD. But there is no organization at the moment who is really so radical that they say, we only work on the savings. So most want to get some money, at least for some kind of more procedures, and then maybe they save some money for the sickness fund, but the sickness fund is not sure whether they will save or not. In our offering, we are saying, we only get money from you, sickness fund, if we have proven that we saved money regarding to the normal development of costs of healthcare. So the normal costs of healthcare in the last 5 years, pandemic excluded, they increased of about 5%, 4 to 5% normally.
Right.
And if we deliver a less increase in healthcare costs, let's say only 2% or 1%, then there's a difference delta we develop, and that delta has to be shared with us. So that's our offering. It depends on the negotiations we had, and in the money we get in helping us for the start-up costs. So in the first system in Kinzigtal, there was a special paragraph in the law that allowed sickness funds to push money into a system like this, and then re-attract the money from the normal providers on the other regions. So they don't pay it, but they had some surplus money for pushing it into the new project. That helped us for the startup. So we got about, I think about 4 million euros from the AOK for the first years. and 1 million was only earmarked for evaluation. So that was quite nice, but today it's very difficult for sickness funds in a more competitive environment to push money in before the savings arise. So our contracts today are in the way that we invest ourselves into these projects for the first years and see until the end of the second year what happened in the first year. So we have a long time gap between knowing what are the costs of care and what are the savings and the doing. So we need for the first 2 years a full replacement by investment. And in a situation like this, we ask for about 75 to 80% of the savings, of the delta, of the share. And in the other way, we had about 50 to 60% of the share, where the sickness fund paid in advance.
Okay. So if I understand correctly, the sickness fund pays the traditional way that it does all over the country, which is mostly a fee for service. Hospital, doctor, pharmacy, any of that.
Yeah.
But then we're monitoring the spend. Is it 1 year or is it a multi-year?
Multi-year approach, yeah. No, 1 year. Every other year will be recorded and will be calculated, but it's a long year contract.
Yeah. And then when there's savings from projections or the national average, then that's split on a predetermined, okay. Right. So you mentioned about some of those funds, especially when there was upfront investment, but now when you have to handle the bill as the ACO, if you will, that evaluation is a big part of that. Can you talk more about how you go about evaluation and what you're learning?
We started evaluation just at the beginning of Kinzigtal already. Because we knew about the discussions in the US that evaluations came a little bit late for managed care. And so we thought that we should have evaluation really from the beginning to be able to demonstrate that this new payment system is not in any way reducing care, necessary care, or producing any other kind of hazards for the population. And so we started with different evaluations. We started with evaluations on the, in Germany it's called under, over, and feel and problematic care that is being delivered for patients. So either too small, so not enough care, or too much care, or the wrong kind of care for the people. And we had a period of the first 5 years, then another period of years, and just it's now in June this year, another report came out over 10 years of Kinzigtal, and every report demonstrated there is no negative effect of care being produced by the way of our working system.
Any specific kinds of that utilization that are noteworthy? I'm thinking about hospital, preventive care visits, vaccinations, anything that you could talk about?
Yeah, that comes to another problem. The indicators for measures in healthcare are in a steady discussion. At the moment we discuss whether process indicators or structural indicators or outcome indicators are the best to measure healthcare successes. And we are used to use process indicators. For instance, the percentage of medication after certain stages of diseases. Or so you get very small indicators, very small numbers of cases, and then it's difficult to measure a development over time and to compare it and to have it in a validated manner. So we propose now to go forward on outcome measures. And I think we got some very nice ideas now. For instance, what is the mean time, mean age of people that get nursing degree? So they agreed that they have to have long-term nursing facilities, that they have to get into a long-term nursing facility. If we are able to produce a higher age, then we could think that this comes because we had better support in their diseases, so that their disease does not force them to go into a nursing facility, provided that they have the full knowledge about the possibilities to get into a nursing facility. Or the mean age of people that are getting dialysis, or the mean age of people having a stroke or heart attacks, or when they die, or the discussion of the international indicators of avoidable death and avoidable or long healthy years of life as long as possible. So we go into these kind of discussions, and even this tomorrow in the afternoon we have a workshop with the Swiss organization on managed care about this topic. Okay. The process indicators are often in generating a problem. For instance, if we support the use of nutrition or the use of movement and sports to substitute medication for cardiac patients, zum Beispiel, for instance, then we reduce our indicator. So it's a very interesting question, and if we are able to move the age of people with cardiac problems into higher ages, they probably need more medication. So the indicator is in a certain kind of relationship to the ages of the people, to the situation that is around, and so on.
Well, now, some managed care organizations would also then look at those factors but add total cost of care.
Yeah.
That would help, in one way, that would help account for the change in the timing. Would there be more utilization but at a later age, like you're saying with medications? What about the cost of care factor?
We look for total cost of care. So we look for the cost of care for hospital services, for pharmaceutical services, nursing services, physiotherapist services, everything. The only part of cost of care we leave out is dental services in our system now. And we get to a point that in Kinzigtal we have a lower situation of about 7% of total cost of care with the same quality of care. And in our hypothesis is that it mainly derives out of this reducing the progression of disease. So we have the people for some years longer healthy than in the normal system in Germany. And the good thing is in Germany that we have this risk adjustment scheme between the sickness funds, and we can use this risk adjustment scheme as a benchmark group, because a patient, let's say my age, now 67, in Germany, male, without any chronic diseases, the sickness fund may get from the central financing body an amount of about, let's say, 1,300 euro. If I would be in a situation of dialysis, need of dialysis, then probably they would get 20,000 euro.
Yeah.
And so the total costs of care, the normal finances sickness funds get from the central body is relative to the age, to the sex, and to the morbidity of the patient. And so we have the benchmark in this money the sickness fund get. So we can make it very easy. We look for the finances the sickness fund gets for the patients, for these, let's say, 30,000, and then what were the costs, the total cost of care for these 30,000, and see what is the niveau, the level of costs.
I'm glad you brought in risk adjustment, because that's so important when there's any kind of difference between the people covered by a different sickness fund or geographic differences. We see that in other countries as well.
Yeah, and we have one factor in our contract that levels it out, the situation in before. Mm-hmm. So we have a kind of an indexing mechanism, so that the situation in before, if in a rural area, normally the cost of care are lower than in the industrialized cities. Mm-hmm. And so the sickness fund already have a profit there. And so this profit stays with the sickness fund. And only the new kind of difference we developed is being measured for our successes.
So the benchmark isn't simply a nationwide average, but it's adjusted for a geographic component also.
Yeah.
Okay, that is very helpful.
And there's one maybe important thing in difference to the ACO model. Mm-hmm. In the ACO model, the groups get the money from Medicare or Medicaid services according to the patients that have decided to go to this doctor, to this office. Yeah. And it's not related to the region. No. In our region, in our situation, we thought it would be better to take all the patients living in this area into the bottle mm-hmm. for measuring the success, because then our doctors don't have any kind of incentive to rule somebody out or to look specifically for certain patients to get them in. Yeah. There is no false incentive into this in the situation. And on the other way, our doctors have not only the incentive to work with the patients who are enrolled, but as well with the other patients from the same sickness fund. Yeah. So it's more a medical orientation instead of an administrative orientation.
Good, that makes more sense. That was identified by Medicare as one of their problems with that initial ACO model, and they've worked to get better at it. I think there's more room for improvement, but they're at least learning from a mistake, moving in the right direction. Yeah. Talk back to cost of care. You mentioned you're watching cost of care. Overall, it's down about 7% versus the benchmark. Did you see any interesting changes in the categories of care? You mentioned hospital, drug, etc.
Yeah, hospital care got down. But that's quite clear because of the incentive. We have an interest in improving ambulatory care and reducing hospital care, because that's tertiary care is always the highest total cost of care.
Yeah. And what portions of the care, what segments went up?
Yeah, we had some going up with the physiotherapists, and we had some going up with the nursing care, with the ambulatory nursing care. I have to explain, the nursing home care in Germany is with another kind of insurance.
Yeah.
So the costs for nursing homes are not included in our calculation, but only the costs for ambulatory nursing.
So if a person lives in a nursing home but they go for physical therapy,
then the costs are included.
Back to the nursing home.
Yeah.
The outpatient physical therapy is included.
Yeah.
Okay.
Yeah.
Got it. So you saw that increase. What about on the primary care prevention? Did you see those services increase? So the amount of money being spent on those increase?
That's our own money we invest. Sure. Prevention, self-help groups, self-management, support for patients, that is being a large part of our investment into the healthcare and into the health situation there.
But those funds come from the savings, not from a fee-for-service payment.
Yeah.
What about pharmaceuticals? Sometimes pharmacy increases in order to reduce hospitalization. Did you see that?
That's possible, but obviously because of our efforts as well to reduce polypharmacy, it mixes to the same level. Okay. So we had no increase in pharmaceutical costs.
Okay. On the regulatory side, have you seen policymakers provide feedback? It's been quite a few years since the initial legislation. Has anything new happened on that side?
Every policymaker who gets to Kinzigtal is excited. And they say, oh, wonderful, we should have it overall, the situation.
Yeah.
And then going back to Berlin, they get into problems because the other people say, oh, that's so complicated and we can't replicate it so easily. And probably it's a very special situation that only is possible in this area of the country with these specific wonderful doctors and so on. And I'm talking and telling them, no, it can be done everywhere. There is no problem to replicate it anywhere. But you need to incentivize the development of these kind of activities. And we think that we are quite successful at the moment. We have a new government being in preparation. And as far as we know, all political parties who are now developing the new government are talking about intersectoral care and new ways of organizing care and new ways of organizing payment. Whether that will get to some kind of a really good incentive or not, we will see. But at the moment, everybody talks about it. And I forgot earlier, now hospitals are getting into the game.
Yeah, because it seems like they should be in opposition the way this has worked. They had nothing to gain, they had everything to lose. Hospitalizations reduced, hospital spending reduced. So how are you getting them to be proponents?
Yeah. When I started in 2000, at the same time I was a hospital administrator. And I had a lot of discussions with my colleagues and a lot of presentations and offerings where I told, let's go forward. We, as the hospitals, we have to run forward and to produce a new kind of system in our areas, improving ambulatory care and reducing the not necessary hospital care, and then developing a stable situation there. But I wasn't successful in getting people to follow this way.
Did you get excommunicated? You're like the 21st century healthcare Martin Luther. No. You get thrown out.
No, actually, I got a lot of interested people. So, because I think even in these times, we started the DRG system in 2000 as well at the same time. So people got hooked up with the DRG transformation. And now a lot of hospital administrators see that the DRG system produces a problem for them. It produces an incentive to get everyone into the hospital, even whether he's sick or not, just to be able to ask for some more payment. And that is, on the one side, an ethical problem for them, for the administrators, but on the second side, as well, a financial problem, because a relatively healthy patient has a CMI, we call this measurement, the severity cost for the DRG payment. It gets, let's say, 0.7 only, and so they get really few money for a relatively healthy patient. And it's much better to get a level of CMI 1.5, having a very severe patient, being able to develop all the professional services, and to have the doctors, the trained doctors working on them. And so the hospital administrators say, we have to look for another way of payment. If not, we will lose money over the time, and we will lose reputation with the population. And there is a big discussion in Germany already at the moment that there are too many hospitals, that they have too many patients that are not belonging to hospitals, that are being cared for in hospitals at the moment. And so the development goes into our direction, so that hospitals think about whether they could take on responsibility for the population in their area. And let's maybe even get kind of a budget sum for all the population, and then reducing not necessary services and producing the right kind of care.
Without being hurt financially.
Yeah.
Right.
Yeah.
I mean, that's the irony, is that for the hospital to act on its intrinsic motivation of helping the health of the community, it harms itself financially.
Yeah.
And as long as there's an open bed, filling it is extra revenue.
Yeah.
Because the DRG is fee for service.
Yeah.
Really.
Yeah. Yeah.
Okay. So, in closing, we've covered a lot of really important issues. You're giving advice to somebody coming behind you on this path. What are the keys to success, and maybe equally importantly, the important pitfalls or dangers that they need to avoid?
Lots of pitfalls. But first, going on for the positive things. Actually, it's not that difficult. If you have either a county and the municipality for some region, or the hospital, or a physician group inside this area, who is looking forward to an improvement in health status for the population. Wonderful. But you need some energy from the region. Second, you need some energy on the side of the sickness fund. And the sickness fund has a problem. They have to give the data of the people living in this area. That is in the discussion of data protection on the one side, and on the other side, the data as being the new gold in healthcare. Is that a difference, a difficult situation for them? But if you don't get the data, you shouldn't try to do anything, because you really need to have a clear view on the problems, what is happening there. You need a clear view on what is happening with your interventions, if it's improving or not. And there are lots of interventions in the marketplace that can be taken into a situation, but may not being productive. So you have to look into the data, looking forward, what is improving and what not. And then third, you need a long-term contract, because you have to invest, and it's an investment over several years until the success comes down, and that does not run in short term. That takes some years. So, but on the one side, if you have some energy on the regional level and a sickness fund who is energetic enough to do it, do it. And take on what is being published in the worldwide literature on healthcare improvement, on population health management, on integrated care, and so on. It's lots of publications that coming out every other week, and there is so much fruit in it that you can use into your activities. That's wonderful. And the good thing is, you earn money by delivering something good for the community and good for the whole society inside one region. And that is, I think, the best motive for your professional career as well.
Okay. Thank you so much, Dr. Hildebrandt. We appreciate you telling us about the backstory on Gesundes Kinzigtal and how it's been working, and your advice moving forward. Thank you.
Thank you.